Solid. When is the meeting? Mute or mute? It's unmuted. Right. Good morning and welcome to the Global Ground Rounds, third quarter 2023. I'm Herbert Oye, and today we have an exciting program for you. And we have Dr.Olu Sandogeyi who will be talking to us, and a couple of our young dynamic medical students will be also presenting, and we'll cap it up with some interesting case studies. The goal of the Global Ground Rounds is to ensure that we continue to provide clinical collaboration between clinicians and hospitals around the world. And today we have the pleasure to also announce some participating physicians hospitals from around the world. Here in Beckley, we have Raleigh General Hospital, our principal hospital, who's hosting the conference. And we also have West Virginia Vascular Institute. We have the Med Surg Group. We also have in Nigeria, the Silver Cross Hospital in Abuja. We have the Eye Care Hospital in Abuja. We have Save a Life Mission Hospital in Port Harcourt. And in Lagos, we have the workings of Endovascular Surgery Clinic in Lagos. Some physicians participating with us today include Dr. Uche Ugoji from Salem Hospital, Warri, and also we have Dr. Michael Sanusi, who will maybe join us from Lagos, cardiothoracic surgeon, cardiovascular surgeon. And we expect the program to go as planned. We may have some technical glitches. If we do, we'll correct this as quickly as possible. So without further ado, I'd like to say again, the program is designed to improve collaboration between physicians and bridging the gap between the third world countries as well as the developed countries and management of cases. Today, we have the honor to present to you all Dr. Olu Sandogeyi, a renowned general pediatric and trauma surgeon here in Beckley, West Virginia. And he has a wealth of experience in this area of expertise. And we're glad that he'll be able to give us an exciting talk on carcinoid tumors. Dr. Sandogeyi. Just give me a quick second. Advance it. Where do I advance it?
Thank you very much, Dr. Oye. I'm glad to be here again. This is my second participation in this Global Grand Round. And welcome wherever is listening. Today, I want to speak about carcinoid tumors. I have to acknowledge the sponsor of this program. Number one, who has been doing this for quite a while, is Oasis Global Health System. And recently, Uzuma Foundation has joined as a co-sponsor. Uzuma Foundation is a non-profit organization based in Florida and Washington, D.C. I am the vice chairman of the board. Cynthia is the chairperson of the board of directors. It's a non-profit organization basically formed to help improve healthcare in Africa and needed part of the world. There is a sister organization which is for-profit. It's called African Diaspora Health System. And it just announced its stopped selling recently. So I will, for all of you that are interested in those two organizations, actually 3 organizations, we'll be glad to provide you with the website for you to review and decide whether you want to be part of us. But this topic is not about them, it's about carcinoid tumors. I don't have any financial disclosure related to carcinoid tumor. Not a stockholder in their treatment program. So that's the first thing we need to address. But carcinoid tumor was an old term, and the correct term nowadays is neuroendocrine tumor, okay? Because neuroendocrine tumor arises from the neuroendocrine cells, otherwise called enterochromaffin cells, mostly involving the GI tract, commonly in the distal ileum, also in the appendix, colon, and recently we've been seeing this in the rectum. Carcinoid tumor, or NET, so I'll be interchanging the terms, but the correct terminology is neuroendocrine tumor. It's not a common tumor, but the beauty of it is that it's one of those things we call interestinoma in medicine. So if I were the one writing a board exam for student or for resident, that's one tumor that I will really focus on and ask a lot of questions. Because, and over the years with my involvement with taking all kind of different board exams, these tumors always take a high percentage of the question. Reason being, you can learn all about your biochemistry, your pathology, your histology, and the morphology and epidemiology from just this one small tumor. It's about 4 out of 100,000 cases of tumor that we discover. Luckily, it's not a tumor that has bad prognosis. The prognosis is good. So 80% of people that has this tumor will survive. It is classified by WHO into 2 main parts. There's the well-differentiated tumor and the poorly differentiated tumor. The poorly differentiated tumor act like a regular carcinoma. The well-differentiated tumor comes into 3 grades, grade 1, 2, 3. So you have to learn all about that. So the well-differentiated tumor, the grade 1 basically just mean that it's a very slow growing. Pathologically, it's only about just less than 2 mitosis per 10 high power field, or 2 mitosis per 2 square meter. The grade 2 is between 2 to 20. And the grade 3, which is getting close to the poorly differentiated, is over 20 mitosis per 10 high power field or per 2 square millimeter. You have to know all those. It's basically graded by the WHO standard. But this was an interesting case that came to me in 2021, and I'm going to just give you a quick presentation. Many doctors always miss this tumor, but the purpose of this lecture is for me to stimulate all of you to review the pathology of neuroendocrine tumors. After this lecture, you should go and read all about it. It's just a very fascinating tumor. It used to be called carcinoid tumor. People still regard it as carcinoid tumors. The reason for using the word carcinoid tumor is that it's really not as bad as cancer, but it's like a sister to cancers. So they basically say carcinoid, which basically means like, you know. So at the end of this lecture, I expected the attendees to understand what we mean by carcinoid symptoms and how to diagnose and treat carcinoid tumor. So very interestingly enough, there's a constellation of symptoms that is very characteristic of this tumor. And that is like flushing, the skin flushing, headaches, diarrhea, and a lot of cardiac problem that can arise. So just review that objective very carefully. I'm going to repeat it because that's the whole purpose of being here. I want to stimulate you to learn more about neuroendocrine tumor. And I expect you at the end of this lecture to be able to understand the symptom of carcinoid and how to treat. and manage it, okay? Now, about sometime in July of 2021, I was consulted on a 70-year-old Caucasian female who presented with 4-year history of intermittent abdominal pain, headache, severe flushing, and diarrhea. These are very classic symptoms of carcinoid tumor or neuroendocrine tumor that are secreting. Well, she has gone to so many hospitals, including the high-valuing tertiary care center like Wake Forest Hospital. Nobody could figure out the diagnosis. It presented to us at Raleigh General in July of 2021 with all the symptoms. Just from listening to her, I kind of suspected that this is what it had. In my many years of practice, I think I've seen about 5 cases, but many grand round and various lectures, I've been very familiar with this. But based on what our examination noticed, distension, tenderness, I thought maybe definitely this patient has got small bowel obstruction or ischemic bowel, and figure out maybe caused by carcinoid tumor. So we did a bunch of tests. The classic test that we always do with this belly pain that we couldn't diagnose is CT scan. And you could see that if you look at that CT scan, you see dilated small bowel, which is the distal ileum, which kind of say, well, this patient has probably got ischemia or bowel obstruction. And I'm going to jump to the pathology just to shorten my time. On the left side of the slide, you will see a lymph node that is got a nest inside it, which is metastasis from this tumor into the local mesenteric lymph node. On the right is a cross-section of the tumor that is stained with chromaffin. Because these tumors secrete a lot of serotonin. Chromaffin is a form of stain that the pathologists use, and the serotonin takes on that stain. So that is why you see that. But in high power view, this is the classic histology of well-differentiated carcinoid tumor. They can throw this at you in your exam and tell you what is it, because it's very classic. You see how uniform the slide is. It's like a nest. And then you see a very like salt and pepper type of thing. And in this patient, it was a grade 1 well-differentiated neuroendocrine tumor. You do not see too many mitosis in this slide. So like I told you, this was a grade 1 tumor. You will see less than 2 mitosis per 10 high power field. In this one, maybe we see about 1. But anyway, just going on, we've talked about the symptoms: flushing, diarrhea, cramping abdominal pain, bronchoconstriction, bronchospasm, and a bunch of valvular lesion. Now, why is all these symptoms? These tumors secrete a lot of vasoactive hormone, and the classic one is serotonin, histamine, kallikrein, 5-hydroxytryptophan, and dopamine. So the beauty of this tumor is that it has all these biochemical compounds that you are supposed to know as doctors and what are the effects on the human body. But most of these tumor, 80% of the tumor will secrete serotonin. So we just review that very well, look at the symptoms. I'll repeat it again: flushing, diarrhea, abdominal pain, bronchoconstriction, bronchospasm, valvular lesions. And occasionally they will have altered mental status like this patient had. But classic over the past 4 years before coming to us was the flushing, and just basically blame it on being menopause or something, but the flushing was more than usual, okay? So now this is just another CT scan that shows the obstructive part of it. Now, how do we diagnose it? We've talked about PET scan, CT scan, and of course, just a general physical exam, listening to the story and see whether you can make diagnosis. Like I told you initially, most of the findings of this neuroendocrine tumor are in the small bowel, i.e. ileum. Next to the ileum is the appendix. And then you also have rectum, colon, and of course, lung. 30% of the time they involve the lungs, okay? Now, so surgery is one treatment. 1 out of 300 appendectomy that is done always show carcinoid tumor at the tip. Okay, so, but usually they are very non-symptomatic. You take out the appendix and they're fine. Most of the appendiceal carcinoid tumor is in the distal tip. More and more now, we're seeing more rectal carcinoid. In the Asia and Pacific area, there are a lot more colorectal carcinoid. In Europe, you see a lot more gastric carcinoid tumor. In this country, it's all distributed everywhere: the lung, small bowel, colon, rectum. And as you also mentioned, I mean, you all have been aware of PPI, proton pump inhibitor, that we've been using frequently. And many people are on it for 10 years and not supposed to be on it forever, but patients don't want to get off it because it treats their dyspeptic symptom very well. Doctors forget to stop it. And we are finding out that on chronic PPI user, you have gastric carcinoid tumor, gastric NET, neuroendocrine tumor. Luckily, they are indolent, they are not aggressive. So be aware of all this as you treat your patient with PPI. Surgery is one mainstay. Obviously, in this patient, I had to do surgery and resect the ischemic bowel and the obstructive bowel. Okay, 4 of her lymph nodes were positive for metastasis, and that's why she was having the carcinoid syndrome. Now, the treatment is to use the medical treatment if after you've done surgery is to do somatostatin analog therapy, because this tumor, they secrete all these vasoactive hormones, and on their receptor, they have somatostatin receptors. So if you have something to block that, like sandostatin, you can treat their symptom very well. So this patient is currently, because of her symptoms, currently being treated by the oncologist, being followed up regular PET scan to make sure there's no recurrence, and being treated with sandostatin and doing extremely very well. There is a nodule in her lung, which is 11 millimeter, and we thought, because you remember 30% of this NET we occur in the lung. So we thought maybe this 11 millimeter tumor in the lung is part of it, but every year they repeat PET scan and it has not grown. So we don't think it is related. So it's probably one of those nodule that is non-problematic. Now, prognosis is good. Like I told you, 80% of them lives to be forever. Slow growing, good survival rate, but the symptom can be annoying and disturbing. The interesting thing is the cardiac valve, that it affects both ventricles. There is a disease that when I was in medical school, we learned quite a lot in Nigeria. It's called EMF, endomyocardial fibrosis. The carcinoid heart is very similar to that. EMF is common in the rural and poor community in Nigeria, Uganda, and all this area. And there's a lot of study going on as to the etiology of it, but it's very similar to the carcinoid heart, surprisingly enough. But I've not been updated on EMF or carcinoid heart to really know the relationship very well. So it's slow growing, it's good survival rate, and then it's just a fun tumor. But you have to know it because it's a favorite of the examiner in the questions because of all the biochemical and the interesting thing about it. Questions?
I do have a question. So you said 30% of the lung tumors. Now, is that primary?
No, not of the lung tumor. 30% of the carcinoma occur in the lung.
Is that a primary tumor of the lung or is that a metastasis?
Primary. primary. And then about 55% are causing the intestine, 16% in the, about 5% in nephrological side. But main thing is the lung and the intestine.
One more question.
Sure.
So to my knowledge, usually before symptoms can come, there's usually some sort of metastasis to the liver. Is there any specific screening you suggest that we go look into the liver to see if there's anything?
Well, obviously, if you have this symptom compilation, you have to do a CT scan to check the liver, but you are very right. Most of the symptomatic carcinoid is related to metastasis, okay? And then there's something called carcinoid tumor crisis, which is dangerous, and you have to treat them aggressively. But yes, liver metastasis is one of the well-known things. But let me just repeat, when we talk about 30% in the lung, we're talking about distribution of carcinoid tumor. So if you have 100 carcinoid tumor in your pie, 30% of that will be in the lung, 55 in the intestine, and the rest everywhere. Now, in the olden day, we used to talk about pancreatic islet tumor. That's all pancreatic NET. They don't call it pancreatic islet tumor anymore. It's now called pancreatic neuroendocrine tumor, just FYI. And carcinoid, the new name for carcinoid is NET, neuroendocrine tumor. But people still interchange those terms. So it's very interesting to me. Go ahead. Any other question?
Thank you for your presentation. I couldn't help but catch your attention with regards to the appendectomy.
Correct.
Factor you mentioned. I had not heard about neuroendocrine tumors showing up at 1 in 300.
Yeah, 300 appendectomy that you do.
Has that correlated with any sort of worsening prognosis or?
No. No, it does not at all, because most of the time it's an incidental finding. You go in to do an appendectomy for appendicitis, take it out, and the pathologist says, oh, there's a carcinoid tumor at the tip of it. Or you go in and saw a little swelling at the appendix, and you take it out. And actually, the reason why that figure is high is that in female, there's a lot more incidental appendectomy than in male, because when you go in for pelvic surgery, this will be GYN always end up taking out the appendix, thinking it's just take it out, you know. So it's really nothing. The appendiceal carcinoid does not upset the prognosis, no.
Has there previously been, again, I'm not
Sure.
But has there previously been any research with regards to stratifying that data on male, female? Or?
Oh, yes, there is that. It's small. Well, let me talk about the racial incidence. Like many things, it's more common in the African American than the Caucasian. It's commoner in male than in the female. Yeah,
Thank you.
that's a fact. Any other?
One more question.
Sure.
For you. Short of the flushing, the other symptoms can resemble somebody may have Crohn's or also colitis. So how would we, in a differential diagnosis, come to that conclusion without testing, without CT?
Well, obviously, you can diagnose what you just said, inflammatory bowel disease, with endoscopy, colonoscopy, and that kind of stuff. And there's all kind of chemical tests nowadays that to differentiate that. But the flushing itself, I mean, the diarrhea is a similar thing to what you just mentioned, but the flushing is very specific to carcinoid syndrome. Thank you very much.
We'd like to thank Dr. Sandogeyi for that most interesting and stimulating talk. And on behalf of the Oye Global Foundation, the Zuma Foundation, again, co-sponsor of this conference, would like to again extend our heartfelt thanks to Dr. Sandogeyi for the presentation. We'll move on with our next talk. If there are no questions from the audience, virtual audience. Any questions from virtual audience? If not, we'll move on to our next talk.
I have a question.
Yes.
Sorry, more of a comment actually. On the carcinoid heart, thanks again for that wonderful presentation. Carcinoid heart is a big problem. it actually will, occur in about 50% of patients with carcinoid syndrome, and really affects mainly the right side of the heart, and can be very insidious with a lot of valvular pathology. So we do everything we can to really, pick up if there's any time there's a right-sided valvular disease, to exclude that. So it is a big problem. Thank you.
Thank you, Doc.
Sure.
Very well. Any further questions or comments? Okay. I sent it to you. Okay. All right. Well, while we're learning the next presentation, our next presentation would be coming from young dynamic medical student, student Dr. Cristo Lamprakos. The goal of the global rounds is to stimulate our young generation of clinicians and students to think and critical think, and also present their thinking and for us such as this. We have the honor today to have Chris give us a case presentation, and Cristo would be talking on, I'll let him give you the topic.
Hello, everyone. Thank you, Dr. Oye, and thank you, Raleigh General Hospital, for giving me the opportunity to present to Global Grand Rounds. I'm just going to load up my my slides here. Today, we'll be discussing a aortic femoral bypass and why some interesting things kind of sort of came from that, and some other things that we should think about post-surgery. So just give me a moment with that. I don't know, I emailed you.
While we have Chris to work on this presentation, I'll go ahead and talk a little bit on PAD and the endovascular vascular toolbox. I'm Herbert Oye, and supported by my students, Sad Akhtar and Yati Gupta, Patel, and Cristo. PAD is a major problem. It affects over 12 million Americans, and globally it affects about 170 million persons. The amputation rate in the United States over 200,000 per year. That is really small, maybe more than that. and peak incidence usually starts from age 50. In our patient population here in Bethel, West Virginia, PAD age profile starts as early as 30s. And we have significant persons with severe critical limb ischemic issues from age 30 and above. So it's a major problem. The typical findings we get with PAD, we know, and you have the usual pain, the 5 Ps, paresthesia, pulselessness, and poikilothermia, cold limb. But for the patient, the most important thing that they would know is pain. And that's what makes them seek attention. The difference is with PAD, when you have patient population that don't seek medical attention on time and present much later in the course, then you have an advanced case. And that sometimes can spell trouble. Even if you go into restore flow, they may not be doing quite well. There's a concept of relative ischemia versus absolute ischemia. Relative ischemia means if somebody wakes up with pain in a limb and it's less than 8 hours from the onset, they sometimes will seek help. And when they seek help, within that time space, if the vascular surgeon is able to restore flow, they should get better to the usual pre-injury state. However, if they present more than 8 hours after the onset, and sometimes they present 2, 3, 4 days after the onset. In that situation, it becomes very difficult to make them better. Even though we succeed in surgery, they may not do well. So the absolute ischemia, relative ischemia, it's an important concept. When we see patients that have absolute and relative ischemia, how can you as a clinician tell if they have absolute ischemia? The simple clinical test you can do is have them wiggle their toes. If they're able to wiggle their toes, and that tells you that there's still a significant amount of blood flow going to the limb. Once they're not able to wiggle the involved set of toes in that extremity, that tells you that the problem's quite significant. If the contralateral, the opposite limb, they can move the toes very, very well, and the limb that's involved, they cannot, you really should be concerned. Delay is not accepted in that mode. That is really an urgent, emergent situation. And the primary care physician or healthcare provider with the patients such as that should seek immediate medical vascular consultation and help to restore flow. In our community, as I stated before, smoking is a major issue. The other things that we do see, persons who are inactive, sedentary lifestyle, high cholesterol. Genetics is a major issue. If we have PAD problems, there's a 30 to 35% chance that other family members, direct descendants of that family would have it too. And diabetes is a major concern in terms of PAD issues. Persons that are diabetic and also have concomitant renal failure concerns, those patients don't do well. We have to really work hard to restore flow in those patients. When we manage patients with PAD, for the purpose of this, again, ground rounds again, is to make it simple. So when next time you see a patient with PAD, you're able to come to a correct diagnosis in a short period of time. It starts with a history and physical. We know that 9 times out of 10 or 90% of the times you can get diagnosis of most disease processes by doing a good history and physical. And in vascular surgical realm, we pay a lot of credence to the ankle brachial index, which is a measure of the blood pressure of the lower extremity to the upper extremity, which gives us a ratio. If that ratio is 1 to 1.2, it's considered normal. If that ratio is 0.9 to 0.8, it's considered mildly reduced blood flow. If the ratio is 0.7 to 0.6, moderate blood flow reduction. And if it's less than 0.5, that person may have severe circulation deficiency. It's important to know that, just like we know our blood pressure, if somebody presents with an ABI that's quite low of 0.2, and they've never had a problem before the presenter, then you're thinking that's an acute problem. And your management algorithm or scheme would should tell you that's an urgent problem, it's an emergent problem, that they need to be seen urgently. And you cannot say refer 1 month later because they'll lose their limb. Again, the additional testing we do will include CT angiogram, which can give us more detail as to where the problem starts, where it ends. And again, if persons present with significant ischemic leg and there's no possibility of a CT angiogram immediately because they're so advanced, and or the CT testing is not available at the institution that you practice, in the vascular surgery instead you have a C-arm, you can do a catheter arteriogram in surgery and then identify the problem, then proceed with your surgical plan. Vascular surgery is very interesting because it takes a lot of planning. You might see somebody preoperatively and have a grand scheme of what you're going to do to the patient, but at the time of revascularization, things don't usually work out so well sometimes. You must be fluid in your thinking. You must be able to make a judgment to say, well, I'm going to have to do this instead of that, and in order to get good outcome. Ultimately, the best goal that we want strive to get at the end of surgery as an extremity that has a pulse. Vascular surgery is beautiful because come without pulse, at the end of the day, they must have a pulse. And if they don't have a pulse, then you've not done all you needed to have done for them. And again, it's important to understand that this testings are necessary, but your history and physical is the mainstay initially for you to make diagnosis. If, for example, somebody comes to you and they're complaining of back pain, buttocks pain, hip pain, and leg pain, and on your examination of the patient, and again, it's very important, always examine the abdomen because they may have an aneurysm, which you may not know unless you touch the belly. Then if you, in this case, don't have any femoral pulses, then you know that they have occlusion of the iliac artery or the aorta. That's the classic findings of Leriche syndrome, iliac occlusive disease. And that you can then confirm with your CT angiogram and proceed with appropriate intervention as needed. The treatment algorithm for endovascular surgery in our toolbox, I have lots of options. Balloon angioplasty is one, stenting is another, atherectomy, where we percutaneously use devices to shave the plaque off. It could be a directional deal, it could be rotational, it could be orbital. All those things will remove the bulk of the plaque, and then you're able to now do additional treatments such as balloon angioplasty or stenting if need be. Embolectomies, we use balloon devices to extract the clots that may be within the artery or the vein. Hybrid revascularization is where we're going to more lately because it's a nice middle of the ground option for those patients who you cannot treat with the endovascular technology. And I digress, endovascular technology simply means that you're able to treat the patient's problem without a cut, minimally invasive. So if they have a problem in the left lower extremity, you can go through the right groin, pass a wire catheter over the aorta into the iliac on the left and to the left lower extremity. You must have a wire cross the lesion if you're going to treat or offer endovascular treatment. If a wire does not go through the blockage or narrow, and then you may not be able to do endovascular treatment. And we have some devices that sometimes we can use to make a wire penetrate a blockage, then affect treatment. If that's not possible, those are the persons that we may end up thinking the hybrid option, where we do limited open intervention just to extract the plaque so we can get access to that artery, then do the additional endovascular options such as balloon angioplasty and stenting. And we'll talk about that as we go. The whole goal is to avoid major bypass operations if we can, because again, our patients are smokers. When you smoke and you have all this big interventions, bypasses from the groin to the knee, below the knee, and one of the things that would occur is blood clots or thromboses of these bypasses. So if we can avoid that, that's always a benefit. Let's go through a few examples. A 91-year-old gentleman with a history of hypertension, with bouts of hypertension, dizziness, physical examination revealed palpable abdominal mass. What would you do? What test would you do at this point? Again, examination shows abdominal mass. Okay, the abdominal mass is non-tender, but it's there. So if you examine this patient and on the clinical examination, next test you could either do will be either an ultrasound to ensure that it's not an aneurysm, or if it's an aneurysm, or to make sure it's not some other mass. But again, with an abdominal mass that's palpable, it's more likely going to be an aneurysm. Again, when you order the CT, it should be a CT angiogram with or without contrast. With contrast, better. Don't order a CT scan of the abdomen with oral and IV contrast in a person that you strongly suspect has an abdominal aortic aneurysm. Because number one, if it's an aneurysm that's about to rupture or burst, and you do that, you'll be delaying the treatment timing, because you have to wait about 2 hours or more for the oral contrast to go through before the test is completed. So again, for somebody that you suspect an abdominal aortic aneurysm, you're better off just doing a CT of the abdomen with or without contrast, or just plain ultrasound to confirm that you have an aneurysm, and then proceed. In this case, this fellow, 91 years old, oxygen dependent, ambulates, drives his wife around and makes his doctor's appointment. He was able to have ultrasound done, which demonstrated 5.7 cm abdominal aortic aneurysm transversely and without rupture. And at this point, the treatment options would be, because it's advanced age, depends on what part of the wall he is. If it's in some part of remote part of the wall, there's no surgical option for him. But in the US, here, he was, we offered him endovascular approach to treat his problem. And he was able to have aneurysm repaired without having to have open surgery. Open surgery would be more debilitating for him because of the incision, either midline or the incision, lateral incision. Then that would be a lot more debilitating for him, given the fact that it was oxygen dependent also. This is the examination showing. Let me go back one. Showing the patient's aneurysm, and you can see the renal arteries, and he did have a very prominent IMA on the left side of the screen, which we're able to identify because we put a tube graft inside the aneurysm. It's like you put a new pipe inside an old pipe to seal it off. Again, when you do endovascular surgery, in this particular case, he had a very long neck. If you look at the distance between the renal arteries and the beginning of aneurysm, you have each marker there's 1 centimeter. So you have 1, 2, 3, 4, 5, almost 6 centimeters length. So that was actually a very good neck for the aneurysm to be anchored, the graft to be anchored. So we proceeded to also take care of his left hypogastric or internal aortic artery. We treated out with coiling, and he did well. And you could see the coils on the IMA, which is shown there, because it was very large. If you don't coil that IMA and the hypogastric on the left, then there may be what we call an endoleak after surgery. the new graft you put in will continue, the sac will continue to expand. And again, this fellow did really well at 91 years old. He was able to be discharged within 2 days of the surgery because it's advanced stage. Usually we discharge him next day, and he was able to go home and he's still running around driving his car and doing all he can do at 92 years old now. Second case, long-standing history of smoking, patient complains of leg pain at rest. And again, what would you do? Again, you start with the standard history and physical, then you do the ABIs. And in this particular case, patient showed aortic occlusion, which required bilateral stenting. This was what we did for the patient because she had severe disabling claudication and rest pain. On the screen on the left, you could see the occlusion. We're able to engage a wire into the from the right femoral into the aorta, also from the left femoral into the aorta. And following that, we were able to get some additional imagery and proceeded to do balloon angioplasty. You could see on the left-hand side, you could see that it's just gray. You could see the dark area, and above the dark area, that's just gray, just plaque. So it's completely clogged up. We're able to do the balloon angioplasty with the balloon inflated on left and right. We open that area and it restored flow. You could see the post-treatment area where on the right-hand side, we put stents, what's called kissing stents, because put one stent on the right iliac, one stent on the left iliac, and then touch one another. It's called kissing stents, and with excellent results. And post-op, you put the patient on some kind of blood thinners, aspirin, Plavix, whatever your preference is. Next patient, 73-year-old person with non-healing ulcer of the left ankle. Again, what would you do? This patient underwent underwent a fem-fem bypass because his left iliac artery was completely occluded, had embolectomy, was performed for limb salvage. This is a gentleman with an ischemic leg who's had previous intervention with a previous above knee amputation and also had left femoral anterior tibial bypass. This has been ongoing. It's had the bypass for about 8 years, which is actually not bad at all. But in 2022, he presented with a cold leg, and the decision to restore flow was made. We were able to make a small incision, which is like hybrid procedure, identify the bypass. The bypass was a Gore-Tex graft, so it was easy to get to, and we were able to do embolectomy and remove the clot and restore flow with also getting better. And this is a plaque on his left groin going downward on the left screen. The middle screen shows that again. We did some balloon angioplasty work on his profunda artery, and you could see the bypass on the left screen, shooting the dye going down, the tube reestablished, and now the foot's all healed up. And he's ambulatory with the prosthesis on his right leg, even though he has a right above knee amputation. Again, amputations are interesting. We don't like to do amputations, so if we don't have to, we only do them as last resort. There are two schools of thought. One primary school of thought for the much older generation of surgeons, they just took the limb off. Nowadays, where we seek more limb preservation when possible, and it's important. That's why it's important for us to do good physical examination and early intervention when necessary to prevent limb loss. When we have to talk amputations, always very important that you advise the patients, let them be part of that decision-making process. If they don't understand that they will lose the limb and you just go and take the limb off, they will get what we'll call a post-amputation depression, and that's just as bad. Again, once the doctor and the patient arrive at the need for amputation, the patient accepted the decision, it's also important to encourage them, let them know that they can walk again within 6 to 8 weeks from that amputation time if they do the right thing. What's happened here? This is a patient with left iliac occlusion, missing gap. You could see there extensive disease, bilateral fem pop, occlusive disease at the popliteal level, and were unable to cross the lesion on the left. Patient by history was admitted with cardiopulmonary issues, was on the ventilator. He was on multiple pressors, maxed on multiple pressors, and really could not have anything done. He looked really bad. This was quite hypertensive, even on pressors. So we unfortunately had to wait almost about a week to 10 days before he stabilized. And we did take a chance, and we went in, and we were unable to cross that lesion even from above, below, and we did a fem-fem bypass. And you could see the artery on the left, and you could see the contents that we took out or retrieved from the left groin femoral artery. Again, this is another case presentation. The gentleman presents, 70-year-old gentleman presents with increasing right groin, right lower extremity pain. Is had by history in 2018, left common femoral artery endarterectomy for a similar event. Also on this CT angiogram, you could see extensive disease, femoral popliteal at above and below the knee. We presented because he wasn't able to function. He leaves alone, and when he gets down, he can't get up. So we offered him intervention. This was a case where we did hybrid intervention. We were able to make an incision in the right groin, interrogate the right iliac artery, and ballooned and stented the right iliac artery, area of stenosis, external iliac artery specifically. And then we were able to remove extensive amount of plaque from the artery. The artery was shattered because of the extensive amount of hard calcified plaque. It was torn, and we really did not want to do a complete interposition graft. So we did a Gore-Tex graft, cut about, made it a patch, but a patch tube graft kind of. So we're able to do that. That's what you see on the far right. And his profunda also shattered because of the plaque. So we had to do also a patch on the profunda. And that's the deep femoral artery. That's on the top portion where that little square, white square is the profunda artery, and the longest marked portion on the left is the portion that comes from artery to superficial femoral artery graft portion that we replaced. He did well, went home on post-op day number 2, and is doing quite well. This for patients that sometimes present with renal failure. They are on dialysis. They sometimes present with blockages of the fistula, and this is a case where you could see she goes to dialysis. She has high venous pressure during dialysis, and you could see the high blockage now and there in the collateral circulation above it. We're able to cross that very easily with the glide wire, and able to stent it, and with a cover stent with excellent result on the right-hand side. That patient goes to dialysis and no more issues with that. You could see the balloon segment, the stent in place. This option I just mentioned can be done in an office-based setting. It does not have to be in a major operating room or cath lab. Procedures that can be done for renal patients, so they can go back to dialysis the same day with minimal interruption, no cuts involved in that situation such as that. Patient presenting with left foot gangrene with left iliac occlusion. I think you could see the extensive, this was just last week, the extensive amount of plaque from the common femoral artery on the right and the left. Again, our patient population present with this, so it's not like they live in Hollywood, we have perfect arteries. In West Virginia, we have bad arteries, and that's what we see. So even a 30-year-old person would have an artery such as this, or contents of an artery such as this. So that's what we see on a routine basis. Right tibial stenting, carpet stents, fem bypass so that's a hybrid intervention. Again, this is not a patient. When you see the picture on the left, you can see on the left limb everything's nice and clean. On the right side, at the groin area, there's a missing segment. That missing segment was significant. Again, it's right over the femoral head. Again, bad surgical technique is to put a stent over the femoral head. If you put a stent over the femoral head, the person sits down or squats, they can fracture that stent. So it's not a good idea to put a stent at that level. So if you're not a surgeon or vascular surgeon who can do the procedure, please refer them to somebody that can remove the plaque such as this. So you could see the plaque that came out versus putting a stent there, that would have been disastrous for the patient. So this patient had just simple endarterectomy, plaque was removed. And because the reason why this was a better option, again, you could see the profunda and the superficial artery right below the plaque. If you put a stent there, you have possibility of occluding the profunda. The profunda is that vessel that will keep your limb alive. Even if your SFA, the superficial artery that goes to your leg, gets clotted, if your profunda is open, your limb will remain alive. So the SFA makes you walk, and the profunda keeps your foot alive. So that's what we say. So this was a case where we were able to do that, and she was able to go home on post-op bed number 1. This is an interesting case. We had a patient who presented with significant left lower extremity pain, extensive occlusion of his left thigh artery, SFA to popliteal artery. We were unable to come from above, so we generously took a retrograde approach from the popliteal artery and were able to now cross. In our experience, sometimes when you come from the top, either from a left groin from the right groin to left groin in this case, or from the arm into the left groin, you may not be able to cross the lesion. But if you go from the popliteal above the area, like shown here, make an incision and go up, sometimes the wire is able to find the true lumen of the artery a lot easier and makes it a lot easier for the patient. So we're able, in this case, again, not only treat the area of the blocked artery, but we also, because of the plaque burden at the entry point, we had to put a patch. You could see the patch, you see the line of the dark line and the suture line there. So that was the Hemoshield patch that we used to repair the artery because the artery was small. If you just close it directly, you have stricture. So that makes it a little better. And that's the plaque that came out from the popliteal artery. So at this point, I'll conclude by saying hybrid revascularization is a great tool for the vascular and endovascular surgeon to help patients who cannot be treated with endovascular surgery alone, and also patients who need to avoid open surgery due to the added major open surgery, such as bypasses. Bypass is not foolproof. If we do a fempa bypass, a good fempa bypass in non-smoker may last 5 to 7 years. If you do an aortic bifemoral bypass in a non-smoker, it may last 15 to 20 years. Blessed if they're smokers, of course. Again, we find this option quite interesting, and we've incorporated that into our endovascular vascular toolbox, and we continue to push on with this process. I would have my student come up next if he's ready to give us lecture. Again, thank you very much, and this is hybrid procedure. Yes.
Dr. I'm really impressed. I'm really impressed with the progress the vascular surgeon has made with this minimal invasive surgery. I mean, I remember the old day when we used to do open neurosurgery and the patient would be hospital at least 15 days, lot of blood. So this is progress. Questions to you is, when you do your aneurysm stenting, do you have a problem once in a while with injury to the vertebral artery that we used to have when we used to do the open surgery?
With endovascular surgery, you can still have problems, yes. And again, especially in the thoracic more than the lower abdominal. Rarely, in my experience, I've never seen yet an abdominal aneurysm portion straightly below the renals develop those issues, but you can have paralysis. Again, the artery of Adamkowitz, when you do the spinal, anterior spinal artery, where you have thrombosis that can cause paralysis. Sometimes if you're doing thoracoabdominal aneurysm, you may have to put a spinal drain to minimize those risks. Yeah, but that and below the knee, below the renals, we have less that problem, but above the renals, you may, yes.
Well, when you have an aneurysm that is suprarenal,
Yes.
how do you approach that?
It depends on, again, you can have a thoracoabdominal aneurysm with involvement of the visceral branches, and it depends on whether or not you have a straight. We typically start from the level of the subclavian artery on the left. If there's a good landing zone, you can put a descending thoracic endograft all the way to the celiac, if that's the only problem they have, and that will treat the problem. Now, if they have branch involvement, then you may want to do fenestrated graft, where you put stents within those grafts and then occlude and improve the flow. Again, those fenestrated grafts require planning. They sometimes will have these pre-measured and takes time to get those in place.
One last question.
Yeah.
When will you decide, and what will you make you do cardiac arteriogram versus CT angio? When will you make that? How do you make this to do cardiac arteriogram or CT angio?
That's essentially when patients come in, we do the BNP, check their renal function. If their renal function is normal, they're healthy, and you have time, they're not ischemic. They have the problem, but they're not in absolute ischemic realm. Yeah, you can do a CT angiogram in that situation. But if somebody's coming to us and they have advanced ischemia, you want, with advanced ischemia comes possibility of rhabdomyolysis, injury to the kidneys. So I want to minimize the contrast I give. So in that case, I can do the catheter arteriogram with less contrast versus the CT angiogram. CT angiogram gives you a set volume, it doesn't change. With catheter arteriogram, if they have even renal failure, early renal failure, you can cut that, dilute the contrast, and give less. So that's when I would do that. Or if the institution does not have a CT angiography, then that's another reason I would do catheter arteriogram.
I'm sorry, one more question.
Yes.
Since this is a global run, if you want to add a vascular surgery program in a poor resource country, number one, what kind of training do you recommend? The poor resource country, there are surgeons really interested, willing to do vascular surgery and non-vascular surgery. Will you insist on the same training that we have in the US, where you have to do their surgery before you go to fellowship, or will you reduce the number of vascular surgery?
Interesting question, Dr. Sandogeyi, and that's the dilemma. As we do our international work, and as the Zuma Foundation also goes with its planning, we know that the fundamental problem in third world countries, especially kind of Africa, is real. And right here in Bethlehem, West Virginia, a small community, this hospital alone has about 8 C-arms. You cannot even have a C-arm in a whole state, in a country, in some parts of the world. So that's the first problem you have in endovascular surgical planning for treatment. But identifying what I will do and what we've done is it starts with training with forums such as this, where we talk about endovascular technology, talk about endovascular surgery, and have persons that are interested first. Then the second thing would be, if they're already trained and the graduate physicians are ready, or they have a surgical inclination, then it's a lot easier to do maybe mini fellowships to kind of
target them to what you're trying to achieve. It has to be pragmatic. It has to be innovative. We can't just do the standard training of vascular surgeon. It's not going to be feasible. For example, the population in Nigeria alone at 212 million at this time is going to supposedly reach 500 million by 2070. And right now, you don't even have 10 vascular surgeons in Nigeria right now that are 100% there to deal with that. So imagine, so we'll have to take the services of physicians that are willing to learn the technology, and we can train them. And also mid-level persons that are willing to learn, form a vascular team. So it's a team process. Again, when I started my career in 1997, clinical practice, I came to a community in West Virginia that had zero endovascular practice or presence. And I started a program initially from zero. Fellowship trained, eager to work, and I did that and successfully did that. Then moved to Beckley and did about 4 more programs here, Raleigh General, Beckley, Appalachian, Greenbrier, as well as Bluefield, and then 2 programs in Nigeria. So it is possible. If you can do it in rural America, you can do it in Africa. It takes commitment. It's not that it doesn't have to expand. We need to start by getting regional. We need to get regional centers, not only within countries, but within the sub-region, regional centers. So if somebody has an ischemic like in Abuja, they don't want to be going to Lagos. They want to be seen in Abuja because we have somebody in Abuja that can help them. Again, if they have a problem in Port Harcourt, they don't want to be going to Lagos, Abuja. You want somebody to treat them when they're locale. So that's one way to do that. Again, the other thing that we'll work on is the option of virtual technology, where I could be here in Beckley, West Virginia, and have trained associates on the other side that we can work on virtually, see exactly what they're seeing in real time, and give advice and suggestions so the patients will do well. So that's our ultimate goal. And persons that are interested in this technology or this realm, please look us up. We're always doing something.
Thank you very much.
Thank you, Doc. Any further questions from the virtual audience?
I believe there are
Thank you for your presentation. I have no question, just to say thank you for your perseverance.
Thank you, Dr. Gorgie.
Yeah.
We have a question from Dr. O'Shelley, which says, how effective is any surgical or endovascular intervention in diabetics with PAD? Yeah, it's nowadays, our endovascular toolbox is really expanding. We have a tool now, intravascular lithotripsy, which works wonders. So even in diabetics and in the patient population with real bad disease, if we can cross the lesion without opening percutaneously, we're able to offer that technology. If we cannot cross the lesion that way percutaneously, we do the retrograde technique like I showed you. And once we cross through that blockage, we can use IVL, intravascular lithotripsy. The particular brand we have used in our institution right now, Shockwave, it works well. And we've done cases where in 2018, I did a fempo bypass on a gentleman who is now 66 years old, about maybe 4, 5, 6 months ago, presented with a occluded fempo bypass. Traditionally on that patient, he will need a redo fempo bypass. Fortunately for him, at the time of surgery, we had the right leg that was occluded. We went from a left groin to the right iliac into the common femoral area. At that point, we had the option to go through the fempo bypass easily, but something just told me, well, why don't you see if you can open the native artery? So we went through a native artery, and why I was able to go through with assistance of a guiding catheter, and we're able to restore his native artery completely without having to do the fempo bypass. So we totally avoided a radiofemoral bypass on this gentleman, and with the intravascular lithotripsy, and that worked great for him because now he did not have to have 2 incisions. So for radiofemoral bypass, he did not have to have the pain would have endured if we did the radiofemoral bypass. It was done percutaneously with a 6-French sheath from his left groin. So that's the beauty. So technology, yes, you can treat diabetics now. We can treat a patient with renal failure with calcified arteries too. So that's it. Next question.
For you, Dr. Oye.
Yeah.
Can I ask a question?
Yes.
Yes, thank you, Dr. Oye, for your presentation. Many times and good evening, everyone. I'm happy to be in this global war room. But please, this is my observation over the years. I've seen that a couple of your patients have had to do repeat interventions of peripheral arterial disease complications. Right now, I'm just wondering, in your practice or in your institution, do you have any service that that you can refer patients to for lifestyle modification, like disease mitigating services, like having a dietitian, or having a lifestyle practitioner or something like that?
Yes,
because
thank you.
they keep coming, and truly it works. And if you have has it been beneficial? Has it been beneficial?
Yes, thank you, Dr. Dorji, for the question. Again, the paradigm shift in vascular surgery is medical therapy, which consists of gradual exercise and medication therapy, as well as lifestyle modification changes. The additional next step is endovascular therapy. Next step is hybrid. Next step is surgery. With respect to your question, we typically start with our patient population non-compliant. You have to underscore that first. They're smokers, will continue to smoke no matter what you do for them. So it's an ongoing discussion, but we do have the services of dietitian that we send them to if they were willing to do that. Again, the lifestyle modification arm of vascular surgery cannot be understated. It's very important. The hospital itself at this moment in time does not have that, but that's something that we've incorporated into our clinical practice.
Thank you. It should be beneficial.
Thank you. Yeah, absolutely. Well, next question.
Dr. Oye, thank you for a great presentation. I recall while we were performing one of my few procedures, assisting you in a few procedures at our hospital, you spoke with regards to how fast the technology is evolving in endovascular surgery along with the field. How do you plan on potentially mitigating the way that the technology is changing rapidly in North America and incorporating it back into your home country where you develop a new program?
A good question. Thank you. Yeah, endovascular technology has been ongoing for the past 35 to 40 years. And again, the first balloon angioplasty procedure was done in 1974 by Charles Daughter. And since then, it's just expanded and exploded. We know that every day companies are coming up with new tools, new ways to make things better. And we'll continue to see that. Again, AI is a big issue. AI is the next generation. And again, we cannot translate what we do in America to any other part of the world if we're all going to go there in person alone without teaching and training the persons on the other side. It's not going to be feasible. Like Dr. Shangari mentioned, you need the end users on the other side to be part of this program where we're able to go teach and have them do it. And that's why we have the Endovascular Conference for Africa and Rural America every October. Not only do we present, I have speakers from around the world that help with, that give us a generous of time to help with that, with teaching. I actually also go in person to the continent of Africa and then do practical examples and training for those physicians. And we do that on a regular basis. We would make trips to Nigeria and other parts of the continent now every 8 weeks or so. And that's part of the process. So it's the virtual technology arm that I mentioned before would be a great way to do that. We have a tool. If I'm operating on a patient, I have the camera on my glasses that I can actually demonstrate what I'm seeing to the physician, say to the Dr. Ugoji and Mori, he can see exactly what I'm seeing. So that's the next wave. And we'll develop that, and we'll continue to develop that. I think we need to make this a little easier. More importantly, we have to have participating hospitals and physicians like like I just mentioned at the beginning of this program, the Zuma Foundation, Silver Cross, Civil Mission, Salem Hospital. All those hospitals have to have a program where we're able to identify the services that we feel will be beneficial to their population. If they're having a lot of gangrene in their patient population, and we know it's from pervasive disease or even diabetes, we can work ways out to kind of make sure those patients are seen or treated, if not by them also, but by us virtually, so they can get all the complement of treatment options that are available to make sure people don't lose the limb. So yes, that's the way to go. Yeah. Any questions? Questions from the virtual platform? I think we may have one. No. Okay. All right. Okay. I think at this point, at juncture, I'll let Cristo Lamprakos, my young dynamic medical students, come in and present, because again, this platform is for the young and as well as old. So they're supposed to be the future for vascular surgery and medicine. Thank you.
Thank you so much. I apologize for the technical difficulties. I'm going to load up my presentation shortly. Share this one because I thought it was.
On account of the problem with technical difficulties, Dr. Lamprakos talk, we'll get Dr. Patel to start with his talk. And Dr.
Again, good morning, everyone. Thank you so much for allowing me to to present today here at Global Grand Rounds. Today, I'm presenting an interesting case that we came across with Dr. Oye while we were in our surgical ward duty with him. Let me just go ahead and present the slides. Okay. All right, so the case that I'm presenting today is a hybrid endovascular approach to an open anterograde iliac artery embolectomy with post-thrombotic stenting, which was complicated or prolonged by a subsequent retrograde popliteal artery embolectomy. And I have nothing to disclose, I promise. So the goal of this presentation today is that hopefully I can showcase a rare presentation of an arterial embolism and highlight the possible intraoperative vascular complications that one may potentially encounter. And again, I'll add and reinforce the existing case reports in endovascular surgery and hopefully build upon some of the future curriculum that we will build together with Dr. Oye for the fellowship program. And highlight the importance of developing good intraoperative decision-making skills and being versatile in any endovascular surgery, as you'll quickly recognize that endovascular surgery, you may plan one thing going in and you'll come out on the other side doing something completely different from where you started. So you must be very versatile. And also I'll highlight the importance of maintaining a high surveillance of peripheral vascular disease in all forms of extremity pain, and not to just exclude it out as any sort of MSK, musculoskeletal pain from the get-go. So just a quick review of the patient today. Our patient is a 53-year-old male with right hip and leg pain. And the story before we came across the surgical consult for the patient was that the patient had previously approached our emergency department and was initially diagnosed with sciatica. At that initial moment, the patient did not have any issues with their pedal pulses. Pedal pulses were detectable, they were present, and then the patient was sent home. The patient then subsequently approached another ER in the city that they were located in a week later. And at that point, pedal pulses were not notable, they were absent. A CT runoff was conducted at that facility and they had concluded an impression of occlusive thrombosis of the right lower extremity and a non-occlusive thrombus in the left lower extremity. And following that impression, they were transferred back to our facility for a further vascular surgery consult. And now the clinical presentation that we encountered once we followed up with our patient at our facility at the vascular surgery consult, the patient reported that they had a slow onset of pain over the last week, which was dull initially, 2 out of 10. And now upon meeting the patient described the pain to be sharp and stabbing, 10 out of 10. Initially, the patient had some bilateral lower extremity weakness, which was now more severe on the right side. Again, that plays into the same picture that I described to you earlier, the impression report showing right side having an occlusive thrombus. Upon physical examination, we found that there was bilateral lower extremity edema and there were absent right lower extremity pedal pulses on vascular Doppler. So quick recap of the patient's past medical and surgical history. Medical history was notable for nicotine dependence, obviously in the form of smoking, and marijuana recreationally used by the patient. Surgical history was notable for bilateral lower extremity crushing injury because our patient was a timber or wood cutting worker and had an accident 6 years ago. And the patient also subsequently went in a quite extensive bilateral lower extremity orthopedic reconstruction for that same accident 6 years ago. So our preoperative evaluation. Our pre-op diagnosis were obviously peripheral vascular disease, and they were subacute or acute limb ischemia with 1 week of onset and pain of the right lower extremity. And the reason why we put pain as a separate diagnosis was because we did not have a specific specimen right in front of us to prove that our theory was correct. And so our pre-op diagnosis included pain as a independent cause or independent diagnosis, which we will obviously narrow down once we proceed with our management. So the form of management, obviously, we proceeded with was the surgical option. Due to the subacute presentation of this pain, we decided that it would be best that the patient received an intraoperative on-bed CTA with runoff, and then we will be determining the course of action. Obviously, we gain patient consent for potential angioplasty, potential stenting, embolectomy, and arteriotomy. Patient was informed of our recommendation, and the patient was in complete agreement with our proposed course of action. The emergency surgery was then subsequently scheduled for that same day. So our first intraoperative arteriogram. So here's where the story starts. We had conducted the first arteriogram from the left common femoral artery. Obviously, we started with a micropuncture needle for French sheet access, and then upon using the pigtail catheter, we found that there was a complete occlusion of the right iliac artery at the origin. So we see right over here, it's a complete occlusion. And then we proceeded further to pass a wire access from the right side. Now, on the left side, we had access via a micropuncture needle, which was minimally invasive on that side. However, on the right side, we had to perform a 4-centimeter incision to access the right side vasculature. So we went in from the right SFA. We inserted the pigtail catheter beyond the occlusion with the guide wire obviously having been passed beyond the occlusion, and then we performed another arteriogram, and we found that there was obviously a complete occlusion of the right iliac artery at the origin, with increased assurance from our side, having had now passed the wire across the occlusion. And once we had passed the wire across the occlusion, we added a Fogarty catheter to hopefully remove the emboli. And one of the questions that I asked Dr. Oye during this procedure was, "Hey, Dr. Oye, how do we know for sure this is a emboli versus a atherosclerotic process?" And one of the obvious answers, at least for a surgeon, would be, well, it's subacute in presentation. But it also adds to the fact that the patient also did not have very strong factors that would cause them to have subacute atherosclerotic process versus an emboli. And the history also was of notable concern. And so here we have a specimen of the iliac artery thrombus that we were able to remove with the Fogarty catheter via a retrograde insertion from the SFA to the common right iliac artery, and then we removed it in an anterograde fashion. And as we proceed further, our intraoperative story gets a little bit more interesting. We encountered that there was some residual stenosis still on the right iliac artery. And so we decided that we will be performing stenting with angioplasty as well on the right common iliac artery. And here is what we ended up using. So we ballooned the right common iliac artery with an addition of 2 covered stents. The first stent was deployed distally from the origin of the right iliac artery, and that was a 10/60 stent, covered stent. And the second stent was deployed subsequently after the first stent, and it was deployed more proximally. And obviously it was overlapped. And here is an image of the exact stent that we use. And obviously for disclosure purposes, I've left out the brand name, but here's an same example that we had used. And as we proceed further, so this was the first stent that we had deployed, and I'll move on to the next slide and we'll see the progression. So after the deployment of the 2 stents, we are now also doing an additional balloon angioplasty that covers the origin of the first stent, and we proceed further down in the middle and then distally towards the extremity, and we also balloon further towards the bifurcation point. And as we proceed further, we conducted another arteriogram, and it shows beautiful patency on the right iliac artery. And here's where it gets more interesting, or rather complicated. So our intraoperative story continues with us having been attempted to palpate for the femoral pulses, which were intact. but the pedal pulses were still absent. So what's going on? We tried to do a Doppler and there were still no pedal pulses detected on the right lower extremity. And that's when we made the intraoperative decision to conduct a CT runoff, a arteriogram runoff, and we performed the cine arteriogram to identify the distal right lower extremity occlusion. And we did in fact find a occlusion, and it was a popliteal artery occlusion. So we'd see a very beautiful image outlined over here with tapered edges on both sides of the thrombus. So as we progress further, again, here's the same image, but with a different setting on our machine. And we noticed that there's a complete occlusion with tapering on the edges and complete occlusion of the popliteal artery just before the bifurcation point. And as we progress further, we used a Fogarty catheter. We were able to pass a wire and then insert our Fogarty catheter, and we inserted into a retrograde fashion towards the popliteal artery, and then removed in a anterograde fashion insertion and retrograde fashion removal. And here's our specimen for the popliteal artery thrombus. Again, a very beautiful thrombus on this one. Came out exactly like the architecture of the artery. And here is the complete patency of the artery following the removal of the embolus. However, we did have some distal popliteal artery residual stenosis as seen on the bottom over here. But at this point, we decided to end the procedure due to the increased prolonged length. And at this point, we did have, we were able to detect the pulses with a Doppler and on clinical exam on the right lower extremity. And we decided that we will reevaluate after clinically with heparin therapy and then evaluate further. And again, this is just an image of the residual stenosis that was discovered on the image, but we did find that there was adequate flow on clinical exam as well. And like I mentioned, pedal pulses were intact and they were detectable on pedal Doppler. So now closing up our intraoperative story, closure of the femoral artery site was with the primary closure, direct arteriotomy. We used a 5-0 non-absorbable monofilament suture, and we also used 2-0 non-absorbable monofilament sutures additionally for arteriotomy site, interrupted sutures, and we ended up closing with 2-0. And here is our specimen side by side again. The specimen was documented in length, and the specimen was also sent to pathology for confirmation. So now that we're out of the OR, what is our post-op diagnosis? Well, our post-op diagnosis still stands: peripheral vascular disease, and more specifically, it was thrombosis of the right common iliac artery and right popliteal artery. And this was obviously a subacute or acute limb ischemia, 1 week of onset, and pain of the right lower extremity. And our postoperative management, obviously, because this patient just had a thrombus formation, chances of restenosis remain high postoperatively. And with the addition of heparin-based products, the patient would have a very great prognosis postoperatively. And therefore, an option was made to maintain the patient on heparin postoperatively. Obviously, we will ask our nursing staff to conduct Doppler limb assessments for flow as per the protocol in-house, and monitor the 6 cardinal signs of peripheral vascular disease postoperatively as per nursing protocol, and also maintain our patient on GI prophylaxis because GI bleeding also remains high for a patient who just had a very stressful procedure, however minimally invasive it may be. We also opted to give them GI prophylaxis, and also because the patient just had an episode of prolonged 1 week onset of acute limb ischemia, it is in our best interest to also provide pain control for the patient, because they're now going to have reperfusion to an area of their body that was previously just cut off a few minutes ago. And so we also provided pain control in the form of opioids and also gave them PRN as needed, acetaminophen, paracetamol. And our outpatient management. So obviously our patient remains at a lifelong high chance of reoccurrence, and therefore it will be left upon the clinical judgment of the primary care provider and the vascular surgeon to decide upon which oral, novel, or injectable antiplatelet therapy that they use. And we also followed up with our patient within 1 week, and we will continue to follow up with our patient for this year. And so now looking at the prognosis, our short-term and long-term prognosis. Short-term, like I mentioned, prognosis will obviously depend on the severity and time frame of the limb ischemia onset. It will depend based on how much of the limb can you salvage. If you can get rid of all of the thrombus, well, you've got the leg back. If you wait days, months, you'll most likely develop and progress towards gangrene. And long-term prognosis will depend on medical compliance due to the embolic nature of the occlusion. But one must also consider other atherosclerotic comorbidities, such as prophylactic treatment of peripheral vascular disease, early recognition of peripheral vascular disease, smoking status, diabetes, lipid status, malignancy, genetics. So what I'm trying to say is that long-term, it will be multifactorial. You can develop an occlusion in another form. It might not be the embolus that you had the first time, but it can also be atherosclerosis, being that the patient was fairly younger in presentation. And just ending off, further areas of initiative prior to diagnosis of, our patient had a diagnosis of sciatica. And so every instant that a clinician thinks of providing a diagnosis of musculoskeletal pain or neuroimpingement pain, one must consider and exclude peripheral vascular disease with a high accuracy. It can really save someone a limb, quite literally. Maintain high surveillance of the workhouse triad. Basic things come first. In our patient had no history of stasis. There was no history of going around driving 12 hours to Disneyland from West Virginia. Patient had no history of hypercoagulability state, but patient did have a history of endothelial disruption. Now, we would think endothelial disruption meaning a fracture a couple of days ago, a few weeks ago, but for our patient, it was 6 years ago. It might not be acute, but it can be years ago that they've had a accidental injury for that vasculature years ago, and now they present with a thrombus, and it fits into the same triad, workhouse triad. And so we always want to maintain a high surveillance of the triad, however long it may be. And embolectomy must not be delayed, obviously. And once the thrombosis has been identified, an anterograde or retrograde embolectomy can both be considered as a viable option for emergent cases just like ours, where we performed an anterograde on one side and retrograde on the other side. And just ending off, a few acknowledgements. This presentation would not have been completed without Dr. Oye, our chief surgeon, and our surgical staff at Raleigh General, anesthesia team at Raleigh General, and my two best colleagues, Cristo and Tejas. Thank you so much for being the best surgical assistants. And at this point, I'd like to give some time to the audience if they have any questions, concerns.
I have one question. So when you have the occlusion, what gives you the indication it's more of a clot than rather than afferent explosion? I think you touched on that, but can you just elaborate a little bit? So obviously on our clinical presentation, for a patient that you're expecting to have any sort of coagulation abnormality, you would get a H&H. Hemostasis and coagulation studies will be conducted. And those studies will obviously show you that they have increased fibrin degradation products. And you would also conduct they'd also have pain. Pain will be one of the first common signs that they will report. And another cardinal sign that they may have is developing edema. They'll have a swollen edema, and their entire leg will be swollen. And usually what Dr. Oye finds and what we've seen together was absent pulses.
Yeah, on that note, CT angiogram, if you do a CT angiogram also pre-op, the benefit of CT angiogram pre-op, you can sometimes see the plaque, and you're able to do it with the plaque on, with that plaque on, so you can
pretty much tells the plaque. If it's an acute ischemic limb, again, if it's chronic, you see collaterals on your CT angiogram or your catheter arteriogram. But if it's an acute problem, then you're not going to see collaterals. So you'll just see a stop abruptly. So that tells you you have more likely a clot. So it's sometimes a mixture. Okay. On this particular case, he was transferred from a tertiary, from another hospital, and CT angiogram was done, but we didn't have the films. So that's why I decided to do on-table arteriogram immediately. So as Dr. Patel mentioned, we use a micropuncture needle just to do from the left side, just to see what we're dealing with. It immediately found the problem approximately at the iliac, and we're able to now come identify what we're going to do next. And that was the reason why we opened the right groin, because I could have done it percutaneously, but to see all that plaque have gone down would be a lot more work. Yeah, and then you worry about going distally again. By opening, we're able to use the hybrid procedure, go up retrograde, down retrograde from same small incision. Yep. Any further questions from the audience?
Yeah, good morning, Dr. Oye. My name is Michael Sanusi from Nigeria.
Hi, doctor. Good morning.
Can you hear me?
Yes, good morning. We can hear you. Yes, sir.
A quick question. In like sub-Saharan Africa, where the novel anticoagulants might be a bit more expensive for the patients, to maintain patency of your stent or a vessel, do you think offering all the platelets inhibitors will be more effective for the patient, like Plavix or antiplatelet, dual antiplatelets versus warfarin?
Yes, in our patient population, which kind of mirrors what we see in sub-Saharan Africa, I typically, if they don't have allergies to the medication, go with aspirin. I do aspirin and clopidogrel, Plavix, usually. Now, if they have excessive amount of blood clot issues, which I'm concerned about, sometimes we'll do the other options that we do have now. The Eliquis and Xarelto, but if you have to do that, it has to be low dose, so you minimize GI bleeding concerns, or if they fall, have stroke issue bleeding. So, but again, in your patient population, I know you'll have the aspirin was like 75 milligrams. We have 81 milligrams here. I just use 1 to 81 milligrams. If I think they have bleeding issues, that if cost as concerned, I'll just go with full dose aspirin 325. But you certainly can give low dose Coumadin if you want to. Whatever you have, that would work. Aspirin works well. If Plavix is expensive, so aspirin would be good enough. If you have to Coumadin, but again with Coumadin you have to check their PT INRs, would have to be problematic too. So aspirin's good enough if you can. If you have the Plavix, you can.
Okay. Thank you.
Thank you, Dr. Sanusi. Any further questions? Okay, at this point, we'll round up with our last speaker, and I hope he has his technical matters under control so we can get off on time. We appreciate your staying on the platform throughout the process. Cristo, you're next.
Thank you. Everything should be good. Cristo. Yes. Okay. Yeah. No problem.
Give me a quick second.
Is it good? All right, good.
All right, thank you. This is a real life example of endovascular surgery. If it doesn't work the first time, try again. Okay, if your guide wire is not going through, change to a Benson, use the advantage, do whatever you can to get through the occlusion. And this seems like this is what we've done here. Perfect. All right, thank you. Thank you, Dr. Patel. All right, so Without further ado, I'd like to thank Raleigh General, Dr. Oye, my colleague Dami for helping me put together this presentation. Let's begin. Okay, so what is peripheral artery disease? We kind of discussed on this. And what's the main cause? Diabetes, smoking, uncontrolled hypertension. And on physical exam, the 6 Ps, this is what you're looking for. The pallor, pain, paresthesia, paralysis, pulselessness, and poikilothermia, coldness. Out of these, the pulselessness and the pain are the most important to identify on physical exam. Okay, let's jump in. Our patient presentation, patient 57-year-old female, Caucasian, with no history of diabetes or smoking or hypertension. So this is very interesting. She was initially referred to vascular surgery when she was admitted and had complaints of pain in her legs. We identified severe leg ischemia. Patient had a ulcer, gangrene ulcer on the left great toe. And we were seen, she was seen after admission to the hospital. Okay, so once there's ischemia identified and there's no pulses identified, we're going to order CTA. So this was the CTA with runoff that we found. And as you can see, there is a complete infrarenal occlusion. So this is basically textbook Lerici syndrome. There's patency of both common femoral, the SFA and profundas were okay. So as we can see, here's our occlusion. Okay, here's the runoff where you see there is some issues here near the popliteal area. I put one normal CT here so you can see what it should be. You should have 3 arteries here on the runoff, which we don't have. Okay. So what we decided to do, we had to do we dissected into the retroperitoneum. We did 2 bilateral groin incisions to expose the SFA and profunda. The midline incision was made, going through skin, subcutaneous fat, the midline fascia, and into the peritoneum. And then we placed this Brook-Walter retractor, which is the retractor here you see, to kind of help us keep everything retracted so that we can gain access into the retroperitoneal area. The patient had some extensive adhesions that we had to ligate so that we could gain access and to make sure that there were no post-surgical complications, because the EG tube was identified in the stomach. This is an important part to make sure there's no post-operative ileus. Once we dissected down into the aorta was non-pulsatile. So there was no pulses in the infrarenal aorta. So this is not the plaques from our patient. This is from another patient, but I want to illustrate that this is what we did. So we did endarterectomy of the aorta to sort of try to promote blood flow. We did an angiogram to demonstrate the renal artery patency. Once that was demonstrated, we continued doing some balloon angioplasty to ensure that once we placed our graft, the graft would have easier time with having flow. Right. So here's a illustration of what we did. So once that endarterectomy was completed, we used a 14 millimeter by 7 millimeter hemishield graft. It was cut to size. We anastomosed it with a 3/0 proline suture. We were able to put the guide wire. This is when we did the angiography. Some stenosis was noted, and we did ballooning and angioplasty. We then tunneled the graft to both femorals. We were very cautious to avoid any ureter damage. So here's a quick picture of the endarterectomy that we also performed left and right on the superficial femoral to ensure that there would be good flow and there was no issues once we attached and our graft. We also used the Surgisil to make sure that there was no postoperative bleeding to help that. The reason why I chose this case and why I wanted is because post-operative day 1, there was a patient complained of abdominal pain. The abdominal pain was completely disproportional to physical exam. This means there is some sort of bleeding or some sort of irritation of the peritoneum. So immediate XLAP was, the patient was sent for XLAP, and we bleeding was identified from the spleen. Splenectomy was performed, and the bleeding was put under control. So, and then 1 week post-op, the patient came and we had into the clinic for follow-up. The left great toe was doing well, started healing better. Staples were removed. The incision site was clean. There was no infection. There was some edema located on the legs, but that was not concerned. The PT and DT pulses were heard, and they were great. And then we planned for future follow-up. So let's do a quick discussion. So this case demonstrates successful management of a patient presenting with Lerici syndrome. It highlights the importance of some post-surgical complications that can happen. And I want to emphasize, as it's been emphasized, that revascularization can be considered in every patient with severe peripheral artery disease or vaso-occlusive crisis. It can prevent the extent of amputation, which is the main goal of many of us. So here's a quick conclusion. It is important to identify adhesions once you enter the abdominal cavity. Removing these adhesions will lower the chances of future bowel obstructions and other complications. It is completely important to make sure that patients who receive the aortic femoral bypass we do adequate physical exams to identify any possible internal bleeding or any possible peritoneal signs. Revascularization is important, and I would like to emphasize one more time to minimize the extent of amputation. Thank you so much. Any questions if we have time?
Thank you, Cristo. That was an interesting case. We have the pleasure again also to have Dr. Sandogeyi come in this case because he was a consultant who was on call for general surgery. Patient did well without any problem at the time of surgery. There were no obvious issues. There was no evidence of bleeding post-op. Belly was closed, belly remained soft. Then sometime about that night, got a call, patient's having a lot more pain. The pain was out of proportion, like Dr. Cristo mentioned. It didn't make any sense. And again, because patient had complete occlusion of the infrarenal aorta, you would worry about ischemic bowel. My concern was, does this patient have ischemic bowel? Because this doesn't make any sense. So again, we also noted that bicarb was low, it's about 13. That really got me worried. So Dr. Sandogeyi did see the patient early hours the next day and took it from there. Dr. Sandogeyi, any comments on your findings? That's your patient with splenectomy.
Well, this patient had a cherry capsule of the spleen that was bleeding very actively. There was a lot of blood in the abdomen. So quickly, we have told the only solution was to just remove the spleen to be able to control the bleeding. And that resolved the problem. So these are possible post-surgical complications that can happen, and you have to discuss this with them before you start surgery. So everything turned out well. I saw in the clinic, and then went to Dr. Oye for staple removal and follow-up. So everything went well.
Yeah, thank you, Dr. Sandogeyi. Again, this is an interesting case. Again, I've had similar patients in the past, and you worry about ischemic bowel, especially when you have complete occlusion of the aorta. Another beautiful portion of this procedure, again, when you do a uterofemoral bypass, even though you had occlusion at the infrarenal junction, juxtarenal occlusion, it's usually better if you can do a uterofemoral bypass versus an axillary bifemoral bypass, because the long-term patency, it's just better with a uterofemoral bypass if you succeed. In my experience, I'm able to usually remove the plaque from my proximal clamp, restore flow. Then if something else needs to be done, like in this case, lithotripsy showed there was some residual stenosis of the immediate suprarenal aorta. We're able to balloon that, and it worked out quite well for the patient. Again, this was a nice case and nice presentation, Dr. Kristen. All
Thank
right?
you, thank you, thank you.
All right, good job. Yeah, Dr. Shang has a comment, yes.
But let me just tell you what is going to be the next topic, which we're going to have, I believe, in October. Is that the next? In October. So one of the topics I'll be talking about is a universal topic that really impair all of us. You all remember the guy that acted in the Black Panther, young man that died of cancer of the colon. I've lost 3 of my close friends to cancer of the colon within the last 2 years. These doctors highly regarded, the video very annoying. So I'm going to be speaking on cancer of the colon that affect African American a lot more than the Caucasian. And it's a very interesting topic. It's a global topic. So I hope you will all come to the grand round in October. But I also want to imply you to know that in November, myself and Dr. Oye and a team are going on exploratory and practical mission to Malawi. So his foundation, Oye's Global Health, together with my little nonprofit, World Health Mission, will be sponsoring the trip. We will also talk about the Zuma Foundation when we go there. So any of you students that interested in mission trip, we always have the mission trip at least twice a year. Dr. Oye goes to Nigeria like every 3-4 weeks. So I'm not like that, I don't have that facility, but yes, it's interesting to know. You learn a lot when you go on those missions. I mean, there's just no argument about it. So just FYI, Malawi mission in November, topic in October for the grand round. My topic will be cancer of the colon, which is really becoming global and very, very interesting case. I think the name of the Black Panther actor is Chadwick, if I can remember very well. Died only, I think he was only 40 years old.
Yeah. Thank you, Dr. Sandogeyi. I appreciate your help and assistance. Again, once again, we thank you all for joining us today. You could have been anywhere in the world, morning, afternoon, evening, but chose to be with us today. For that, we're grateful. I would like to take this opportunity once more to thank sponsors, Oye Global Medical Foundation, the Uzuma Foundation, Med Surg Group, Silver Cross Hospital Abuja, Bayelsa Specialist Hospital, Bayelsa, Save a Life Mission Hospital, Port Harcourt, Federal Medical Center, Kefi, Salem Hospital, Warri, and Endovascular Clinic in Lagos. Dr. Sanusi joined us from Evercare in Lagos. Thank you very much, Dr. Sanusi. So once again, thank you very much. We'll look forward to seeing you on our next Global Ground Rounds, the 4th one for the year. And also the Endovascular Conference for Rural America and Africa, scheduled for October 19th and 20 of this year. On October 21st, we'll make a trip back to Nigeria for a practical session for persons who want to have practical endovascular experience. We're undecided as to where it might take place. It may be in Lagos or Port Harcourt or Bayelsa. We'll get the details at a later time. So, but again, thank you so much. And we hope that you've learned a few things from the presentations today. And I'd like to thank my young doctors for their tenacity and working hard to make this a success. Dr. Patel here, Dr. Lamprakos, and Dr. Sad, Akhtar, and Yati, who are also studying for board exams. So thank you so much. And we would like to see you on the next time again. Thank you so much, Dr. Gorgi.
I like your party.
Thank you. Appreciate it. Thank you. All right. All right. Thank you so much.
Thank you.
Thank you. Appreciate it.
Hi, Dr. Sandogeyi.
How you doing, Doc?
Yeah.
Good. I see you.
Dr. Gorgi, you also a talk in October, so get ready for your talk in October.
Yes,
All
I'm
right.
waiting for that. Thank
All
you.
right. Thank you very much. All right.
Thank you, sir. Thank you.
Kind regards. Thank you, everybody. Thank you.
All right. Bye.
Bye-bye.
Thank you for next one.
Thank you.
I think